thank you guys for coming. We'll get started. Hopefully a few more people will filter in, but I know it's tough when it's the last session of the conference. I'm Kate Eshelman. I'm the VP of Medical Informatics. Very excited to talk risk adjustment with you guys today. Hemant, do you want to introduce yourself?
Yeah, Hemant Doma, AVP of Product Management at Inovalon.
Yeah. Aaron Birch, I'm the Chief Compliance Officer, Chief Legal Counsel for Alterwood Health, a small Maryland-based Medicare Advantage company.
I'm Savati I'm the Risk Adjustment Program Manager at EternalHealth.
All right, so we wanted to give a little bit of a review, kind of where we are in risk adjustment, what's been happening in recent times. So as we all know, the HCC model sort of came onto the scene in 2004 and introduced risk adjustment into Medicare Advantage. Throughout the years, there's been more and more concerns being raised by CMS around in-home assessments. They are very closely starting to track conditions that were evaluated in in-home assessment that were not then followed up on by a primary care doctor or someone who sees the patient regularly. And that's been sort of building over time. Also, RADV audits are obviously taking off and becoming more and more prominent. And then, the model version changed in Medicare to the versions 28 model, which really got rid of some of the conditions that were often found and documented by in-home assessments. The biggest one being vascular disease. For most people with vascular disease, unless they had real active critical urgent symptoms, were eliminated from this model. Some of the other things, like mild or moderate major depressive disorder, were taken out. Diabetes was flattened. So it used to be a higher value HCC if diabetes with manifestations versus diabetes without manifestations. And so all of that to say that there's been a lot of pressure from CMS and kind of forcing health plans to maybe think about their approach to their risk adjustment strategy, both prospectively and retrospectively. If you want to go to the next slide, Hemant. I think there's pressure towards really trying to minimize those in-home assessments if possible. Only use them when they really make sense for the patient, and really try to get more and more information in front of the primary care provider who's actually seeing the patient and is sort of responsible for the patient on a day-to-day basis and can treat that patient. Now, we all know that things like retrospective chart reviews and in-home assessments exist for a reason. And that reason is a lot of times the primary care doctors aren't addressing those risk adjustable gaps, or the patients aren't seeing them as regularly as one would hope. So that leaves health plans in the situation where they really need to figure out, what is my risk adjustment strategy? And some health plans lean more towards doing more retrospective chart reviews. Some health plans lean more towards the prospective side, which includes the in-home assessments and getting those gaps in front of the primary care doctor. And then the vast majority of health plans are doing a little bit of each. So I think maybe Aaron and Savati, if you could kind of, just from a step back, talk about how your plans deal with risk adjustment accuracy and what are the different ways that you're approaching those?
Sure. Savati, why don't you go first?
Okay. Well, with EternalHealth for the risk adjustment program, we do both the in-home assessment and the retrospective project. And in addition to that, we also do PCP engagement, provide engagement. So what I typically do is I pull out the gap report from the Inovalon Data Insights platform. I slice and dice it, and I push it over to our providers manually.
Yeah, and so just by way of background, this is the second Medicare Advantage plan that I've been with. I've been lucky enough to be on the ground floor for both. And Maryland, for those that aren't familiar, operates in a very unique regulatory environment. And I'm not going to bore everybody here with the details of that, but based on our historical experience, our bread and butter has been and will always be retrospective chart review. That being said, we are constantly chasing our tails, right, with that process. So we have tried to diversify in-home assessments. We've had very little success with that. But since we've partnered with Inovalon, we've become a little bit more intellectual about our prospective in filling in gaps in care.
That's great. No, I agree with Kate and Aaron here. Empowering providers as much as possible in the workflow with the right information and ensuring there's clinical documentation there is the ideal thing to do, right? And more that happens, less the need for in-home assessments and the medical record review. But there's always a place for that from an audit perspective, from clinical care delivery perspective, and also from a cost perspective, right? Enabling providers within their workflow with the right information is always the ideal thing to do. In fact, there was a session yesterday, Mike Jones was leading, and there was one pop-up quiz that came up where they were asking the health plans, their investments for risk adjustment, where are they most likely to invest in the current year? And nearly 42% of the audience, over 100 people, voted for that. Said provider enablement, and 10% said in-home assessment. I think it was indicative of the direction in which I think the industry as a whole is moving, and it's encouraging to see that more and more resources are being deployed to empower providers there, right? So here at Inovalon, we kind of think of care gap closure as sort of three pillars there. One, we have the analytics. That's really important to have a strong foundational analytics where you can do both quality and risk adjustment and other type of analytics as well to identify the care gaps across the member, right? To enable that member-centric interventions to happen when you engage the members and the providers. So that this foundational analytics is important. Secondly, we also partner with a lot of companies. And you can see a bunch of logos here, because we believe that there are companies that are specialized in some form of care gap closure, right? And by including their solutions as part of our solution, really helps our customers to get that very comprehensive care gap closure, different types of modalities there, and to implement that. And this integration is we worked on several months for these kind of integrations, right? And this is backed by HL7 Fire-based APIs, where the data is transitioning back and forth from our platforms to the partner platforms using these real-time APIs. This really helps the health plans to not requiring the health plans to then having to sort of implement these solutions separately, right? So that if the health plan is on our analytics platform, that automatically can benefit from these partner solutions, and whether it is HealthMine or EternalHealth or different partner solutions here. So, but there's a need for a strong coordination engine, right? When you have, for example, one in-home assessment vendor doing in-home assessments, and also have the EHR where you're engaging the providers within the network, it's important to have that coordination engine so that when you know that the patient has gone seen the physician, you have that information, there is no need to schedule in-home assessment, right, for the next 2 or 3 months. Similarly, with the member engagement, when we know that a member has responded to a text message and has scheduled an appointment, then, there's no need to engage that member for other interventions for a period of time. That will minimize the abrasion, that will really bring down the costs. So having this coordination engine is super critical. Otherwise, this risk adjustment and quality functions can sort of do their own thing, do many interventions, not very coordinated, that can lead to abrasion, that will increase the cost, right? So coordination is important here. So foundational analytics, strong member engagement, and then engaging members within engaging providers within their workflow. These are the three pillars that we see. Just around member engagement, Aaron, a question for you. How does the member engagement generally work within Alterwood?
Yeah, so as we had discussed in the meeting room prior to we came out here, so for my health plan, we have a very robust dual special needs population. It's probably our second largest tranche. Actually, it is our second largest tranche, our PBP. We have 2 PBPs for dual special needs. And embedded within that model care is constant communication with our members. So as a data point, what I've found is that our members historically will reach out to our health and quality team more than our own member services team, right? Call center staff. So within that engagement, there is a lot of touch points for reminding the member to close these certain gaps in care, get them to see their preventative care specialists. And that's really the way that we've been able to drive a lot of our member engagement, we've had very limited success on the provider side due to some of the nuances in the state of Maryland. If you were to remove egg whip from the penetration rates in Maryland, we're the third lowest Medicare penetration rate in the United States. And so because of that, we've had a lot of limited success with provider engagement, which I'm eager to hear some of the success that they've had. So our member engagement is largely drawn at a grassroots level, right? Communication via phone, email, text messages. And then we've recently set up somewhat of a one-stop shop portal where we're trying to drive membership engagement through that and online services. So we're starting to make some real headways along that side. So member engagement for us has been effectively the best driver of putting in some of these analytics.
Yeah.
Can you?
There's-
Oh, go ahead. I was just going to ask if you could speak a little bit about the portal specifically. 'Cause we've had a lot of conversations in this conference around AI.
Yeah.
Sounds like there's phone calls, there's texts. Is the portal using any kind of, bots or agents yet, or
No,
are you
we've
trying to keep it bot free for now?
Yeah, Doc, that's a great question. We're bot free for right now.
Bot free.
Yeah, we've seen some of the modules and some of the vaporware, right, that's out there, and we just don't think it's sophisticated enough. And then one of our hallmarks, I believe, at our company is that everybody that works for Alterwood, we don't delegate anything, right, across all of our different service levels. And so the members, and frankly, the provider community itself, we've gotten a lot of high remarks on the fact that the individual that you're speaking to likely lives in Maryland and appreciates the nuances of the geography of Maryland, right? And so because of that, and because of that service level that we maintain, the idea of rolling out bots or canned answers is something a little antithetical to what our secret sauce is. So for the time being, I think we're going to stay as is.
Stay bot free for now.
Bot free for now. Yeah.
And there's really no, as you were saying, there's really no one size fits all type solution. I mean, based on what populations you have and surveying, I think different digital member engagement or even at times the paper-based or mailer might work for some population, right? And really, I think understanding that population really well and understanding what works for them and deploying that type of intervention makes the best sense. And at times really personalizing at the member level, right? Even the content and the modalities. And you mentioned text and IVR and emails and all kinds of channels, and being able to sort of leverage them on a member by member basis and what works the best. That's the type of strategy we take. We take it here, partnered with HealthMind here on sort of engaging members. And we are having some demo as well yesterday. So really cool capabilities in terms of sort of there's some agentic AI calls to automatically schedule the appointment for the patient, which was really effective because ultimately, when you drop a mail, what happens is that you cannot track what happens next, right? And when it's digital member engagement, you can text the member. You know that the member has clicked the link. You know that then they probably clicked the link and then scheduled an appointment, and then they have actually gone to the physician's office, and ultimately the claims have come through. So it's possible to track all of that and really attribute the outcomes back to this particular intervention. That is a bit difficult to do when you're using mailers and interventions like that. But at times it's necessary, right?
Could I add in a point? Actually,
Yeah.
I just thought about this. So from member engagement, this sounds so simple, but if you can hit singles and doubles, it's a lot easier to get your members to engage. And what I mean by that is, so I coordinate all of our supplemental benefits, right? So vision, dental, rides, meals, what have you. And what I've found is if you are able to provide access to the supplemental benefits that you hold out to CMS that you are in fact going to do, right? So if you have the dental network, you make sure that Uber and Lyft are picking up your members if you offer rides, if the meals that they've ordered, if all of that runs, if the trains run on time, everything else kind of flows seamlessly through that. So if you have a happy member population that is in fact getting the supplemental benefits that they've otherwise been advertised and marketed to, all of that other stuff does have a tendency to roll hand in hand. We have these quarterly meetings with our membership community that are fairly well attended, despite some of these individuals living 2-3 hours away. And what we found is if you meet the singles and the doubles that I've responded to, all the other stuff they become much more open to the engagement that you're referring to.
Yeah. No.
And it sounds so simple, but look, we've struggled with transportation for years, and we finally hit it. And now I feel like everything else kind of just flows seamlessly from that.
Could you talk a little more about the hitting of the transportation? Because I think this is something that I would hope has really changed with Uber and Lyft, with, that becoming kind of part of society, and just getting the patient from their home to the visit, in my mind, is a much lower barrier than it was 5-10 years ago.
Sea change, absolute sea change. Yeah, that's a perfect segue. So I've been in some form or fashion overseeing our transportation benefit for about a decade. The old antiquated models were these sedan services that were unreliable. In fact, I use favorite, but it's not great. One of my anecdotes is an old vendor, one of our antiquated ones that's since been sunset, they left a member, and that member ended up sleeping in the parking lot overnight. Yeah, and as you can imagine, as the company's legal counsel, that didn't go over well. Right?
Yeah.
But since Uber and Lyft have rolled out, we're, as a 10,000 member plan, we're doing about 15,000 rides a month. And it's all because of the on-demand services of Uber and Lyft. And we try to reduce as many barriers as possible to utilizing that benefit, meaning I don't try to hard code where they go. I mean, obviously, we don't want them going to the casino or anything like that, but I try not to be as stringent as possible, because there are a lot of social determinants that help. Like, all right, if they're gonna go to church once in a while, that's helpful for better, mental health. So you are able to drive utilization to these preventative services. Mostly that's where they're going, which then in turn improves, medical documentation and risk score. So it's a huge, huge part of it. It really is. That's a great question. Thanks.
Once they actually do go to the physicians, then there is the challenge of really engaging the physicians, right? Making sure they have the right information. So Savadi,
Savadi can speak to that.
You probably speak to that. How does that work for your organization? You mentioned a little bit about sending these reports to your providers and making sure they know what gaps to address and things like that. How does that work? What are some of the challenges you see there?
So some of the challenges that we do see when it comes to provider engagement is the HCC report that I push out. They have to manually ingest that report and try to put it into the EHR system. So that's one of the challenges we get, and it's not in real time. So there's always some reconciliation we have to do. But what I do with our providers is I do meet with them on a monthly basis. We do a little mini JOC. So we have their medical directors, their risk adjustment SME, their quality SME, pharmacy. So it's a one time, every month. We'll go over all of those. I'll go over their risk adjustment performance. We'll talk about their challenges, any barriers, what we can do to help them. So a lot of time they really appreciate that. And we also go over the few HCCs that's remaining open, and they kind of walk us through it, if the member truly has that condition or not. So it's really helpful, and we stay engaged that way.
Have you ever found that it's just a matter of bandwidth with them, where they're you try to be appreciative of the fact that, some of these may be smaller practices, and they're look, I just don't have the time to meet. And then how do you navigate that? Because that's what I run into quite a bit.
Yeah, so we do run into that problem, with some of our providers. What we try to do is at least have them look at that gap report and see if they're working it, if they understand it. There's times where they can't meet with us all the time, but I'll follow up by email at least, and just try to stay connected somehow.
Got it.
So there's a high touch. There's a lot of training for the providers and making sure they understand the report. So that happens. So you spend a lot of time doing that.
Yes.
Seems great. So in terms of if you look at your provider network and what type of EHRs those providers use, how is the spread?
The EHR system, they use everything.
Okay. How about in your case, in Maryland, it's a small, 10,000 members.
The ones you're showing down there on
Everything.
the screen, Epic and Cerner are our two biggest.
Epic and Cerner are the big ones. Yeah. That's typical the case, and that's what we hear from other health plans as well, is that their provider networks, they use EHRs, different EHRs, right? I mean, Epic predominantly but also Athena, Cerner, Meditech, and Veradigm, and all kinds of EHRs. And even I think there are providers, for the most part, all their provider network is on Epic. They have their out-of-network providers using Athena and other EHRs. So it becomes, and if you think of sort of transitioning, I think Savadi mentioned about like sending those reports to the providers and they will manually enter that into the EHR. We have to push that data directly into the EHR. That is easier said than done, right? Because every EHR integration is different. And then you have Epic, which is installed on every health system. That configuration can be a health system by health system type of integration. So we are partnered with all these EHRs that you see here, Epic, and through Vim, with eClinicalWorks and Office Ally, two of the other EHRs, and with EternalHealth and Veradigm, where we are integrated with all these EHRs so that when a patient walks into one of these clinics, there is an automated API call that happens to our analytics platforms. We can transactionally give the gaps to the clinic in a very real-time basis, so that one, they can have the latest and greatest information whenever the patient is coming in, and it is surfaced up inside the EHR, so that providers don't have to sort of navigate outside the EHR. They're busy people, they don't have too much time, right? It's right there at the point of care, and it will really help them with sort of documentation as well, because they can confirm the conditions, and that diagnosis code is directly written to the encounter node. That way it comes to the claims. So we are super excited about this integration. And there is and through the integration with all these EHRs, our goal is to make sure there's a health plan that has how many of our members seeing certain physicians, regardless of the EHR that they're seeing. We want to be able to integrate and push the data to all those EHRs. So pretty exciting stuff.
And I think now that this technology exists, finally, it is, especially with Epic, you really need to go kind of health system by health system to convince that health system to turn it on in their health system. I think that's where some of the challenge lies. I'm guessing for both of you that there are major health systems with Epic, and getting an audience with them and getting them to prioritize what you want them to do within their Epic system can be maybe challenging. And I don't know if you have thoughts on that subject, because I do.
I would love to hear yours, because I'm curious how you incentivize to.
Have you tried to interact with the health systems directly, that through their EHRs?
Through the EHR system, based on what incentivizing?
I mean, sometimes what happens is that when we talk to the health systems providers, and the Epic team, IT that's handling the EHR itself, is completely different from the other clinical teams. And we are talking to the clinical teams and talking to them about Epic integration and whatnot, and they have no idea. There's one more team that's handling. I don't know, in your case, I don't know to what extent you interact with the IT systems and things like that within the health system directly, or is it you leave it to the health systems to manage?
Yeah, and usually the health system manage it. Yeah, not with us.
Yeah, I think that's a challenge, right? And probably the same for you.
Yeah, and as a smaller health plan, we don't really have the economies of scale or the 5X membership that necessarily moves the needle to try to get the foot in the door to have those conversations, right? That's always been a challenge as a startup, sure.
Absolutely. And so I think for the smaller health plans, the Athenas, the Veradigm, Allscripts, that's an easier way to go, because those are cloud-based systems where you can kind of light it up for all of your members without having to deal with, the IT team at each health system that's running Epic. So I think that's definitely an effective strategy to think about, because it is hard to get kind of in their backlog of things that they have to do to make sure that your priorities get surfaced up. So I think that's an important thing that we all want to be doing. We want to get to the point, Savadi, where you don't always have to go and meet to talk about at least the risk gaps. You can talk about other things, but in a perfect world, those risk gaps are already being surfaced to the providers in their EHR workflow, And then your role is more to talk about, are there patients that we're saying have gaps that they don't think that really have them, and have more of those discussions rather than, so I think that's where we're all trying to get, is to get to those discussions so that you're not just showing them the patients that have the gaps, but you're having more robust conversations around how to get those gaps addressed, or to get those gaps out of there, because the provider is adamantly telling you that this patient does not have diabetes, right? And so I think that's definitely the challenge there. So I guess, one thing I'd like to ask you guys is, I think you're in different, have different strategies between your two health plans. Do you see it evolving? Do you see evolving, away from retrospective, more towards prospective, or do you think that you're going to keep kind of doing both for as long as it makes sense to do?
For me personally, I think we are going to continue to do both, just because there's some providers it's just so hard to engage, and some providers might not, have accurate documentation of the diagnosis. So having that retro project, it's very helpful. So it's helpful for reaching those providers that's hard to reach. And the prospective side, I'm just really trying to get the providers to hold them accountable, to see their members, and in addition to that, the in-home assessment as like a second choice.
Yeah, and for me, I mean, obviously, prospective, I would love to put the retrospective completely out of business, right? That way, not only from a cash flow perspective, but just constantly chasing your tail for charts. I just don't ever see that happening. So I've kind of resigned myself to the fact that the lion's share of our RA activities are going to be chasing charts.
So since we're still chasing charts, talk a little bit about, over the past 5 years, charts are easier to get, cheaper to get. Take me through kind of how that's been.
Certainly easier. So this will be my 9th campaign for chasing charts. And I would say it's gotten monumentally easier. One, the majority of the larger health systems in Maryland either participate with MRO or Datavant ScanStat, right? So what I've done is I've just tried to cut out the middleman and develop relationships with both of those chart copy centers and just work with them so I can have a line of sight into their turnaround times. And from a cheaper, no. The chart copy...
Technology is supposed to be
right,
cheaper.
Cheaper, no, the chart copy chase fees are going up. But it's the cost of doing business, right? And then when you take a look at the ROI in terms of what you're paying towards what you're getting,
it still makes sense.
A ton of sense. But it has been a lot easier. So a former vendor that we used, we ended up getting a capture rate of about 90%, our most recent campaign. Prior to that, 2-3 years ago, it was probably around 65%. And I think a lot of that is because the majority of the health systems, have rolled it up to chart copy centers, and making it a lot easier for those returns. The challenge you're always going to face are those independent group practices, smaller practices, where it's the administrative person at the front desk also serves as the chart copy person, and then you're just begging and begging and begging. And there's been times where I'll go out to the office and say, I'll pull them myself, I don't care.
Okay.
I'll make the trip,
That's what it comes down to sometimes.
Yeah.
How about you, Savati? How's chart collection going for you guys?
Chart collection is going well. It's definitely cheaper, so that's like a better option for us too. But
Cheaper than prospective.
Yes, cheaper than the in-homes. So that's
For sure.
Yeah, that's one thing we do, and we do rely heavily on our vendor to do that retrospective chart chases.
I think it's fair to say probably some combination of the prospective in-home assessments and then medical records and then EHR, some combination of that is going to be there for the next foreseeable future.
Yeah.
It's difficult to unwind, really make sure all of the clinical documentation, getting that perfect and the claims being perfect with all the diagnosis codes. That's not easy, right?
Yeah, we've had limited success with in-home assessments really for a number of years. And intellectually, I understand it. I mean, inevitably what you're asking the member to do is to invite someone into their home, right, that they don't know. We try to target individuals that may have had some sort of home health in the past, which tends to open up the door a little bit to inviting clinical individuals into the home. And then frankly, I know that the trade winds are 6 years past it, but COVID really knocked the heels off of that one, where people have a lot of reticence to inviting people into the home, right? So we try to supplement it, but the engagement on the in-home assessments have always been fairly low. And so we just take it for what we get with that one.
Yeah.
It can't be, for us, a core part of our risk adjustment strategy. Because if it was, then we just wouldn't get the returns that we traditionally see.
And you feel that it didn't really ever pick up kind of after the pandemic?
Never.
Just kind of a shift in
Kind of died on
mindset.
the vine, unfortunately. Yeah.
Interesting.
Wait, we have few.
Sure. So yeah, let's just talk a little bit before. This is kind of an illustration of what a lot of patients are experiencing. So, you have a patient who has, a history of diabetes. She might need a colonoscopy. She might need a vaccination. And so, how do we approach that patient? And I think the reality is a lot of times there's different departments that are reaching out to the patient at different times through member engagement, through an EHR, through their IHA vendor to try to accomplish those goals. And that can be a lot of arrows going around. And I think what we're trying to strive towards is really making that process better. So if you think about all of the different ways that we have to access and get that information in front of providers for Mary, we can really diminish a lot of those contacts. And then sometimes we can make it so that an in-home might not be needed. So you take a situation where, there's vaccine outreach for her, there's a in-home to get that diabetes documented, there's another outreach trying to get her colonoscopy. And if we can really get the patient engaged in a right way, understanding, what they need to do. I would always, not as practice, want my patients to come with a checklist, because sometimes you only have such time with your doctor, and you want to make sure you hit all the things that you intended to hit, because the last thing you want to do is walk out and say, oh, I forgot to ask her about this or that, because you're not sure when you're really going to get that time back with the doctor again. So kind of that patient engagement can serve that role of arming the patient with their checklists, right? Make sure you talk about your shingles vaccine, make sure we talk about your diabetes, make sure you talk about your colonoscopy need. And then on the provider side, hopefully the provider also knows what they need to deal with when the patient comes in. And that might be through the heroic efforts of Savani and others like her that are actually meeting with them and running through these patients and making sure they know what they need. It might through their EHR kind of prompting them different prompts that are reminding the patients of these things, so that is maximizing the visit as well. So it is very difficult to put that onus on the patient, and it's very difficult to put that onus on the doctor. You really want to make sure that the patient is coming in focused on what they want to accomplish, and then the doctor also knows what needs to be accomplished, because I can tell you it easily gets derailed. There are more pressing things going on sometimes than whether or not your patient has gotten her shingles vaccine. She might be having trouble breathing or pain in her leg or different things that you're going to spend the majority of the time talking about, because that's why they came in to see you. But you want to also make sure that while you have them and it's precious time that you have together, that you're addressing the other things. And so we need to be thinking about the best ways to really consolidate those efforts so that the patients are coming knowledgeable on what they need to accomplish, and the doctor is coming into the room knowing what they need to accomplish, so that you can actually maximize your time with the patient and not worry about, oh gosh, what did I forget to talk about after they've already walked out the door. It is not easy, but I think that without technology, it's darn near impossible. So I'm excited to hear the things that you're doing. I think we are making some progress here, but we still have a long way to go. And I think that as far as risk adjustment is concerned, it's not going anywhere, and all different strategies are on the table and need to be used to their maximum ability. I think as we see more, and we didn't really talk about value-based contracting here, but the more value-based contracts you have in play, I think the more you're going to get providers really understanding the importance of risk adjustment, to really talk about how sick my patients are, what is their morbidity, and that impacts how they do in their value-based contracts. So I think that risk adjustment is always going to have a role to play. And what we're really trying to do is come up with as many ways to work with the health plans to get that information in front of the docs and the patients at the right time. So I really want to thank everyone for attending. I know it's hard when we're right before lunch, but I want to thank Savati and Aaron for joining us in this conversation. And any questions from the audience? No? Where's lunch? Maybe is the question. All right. Well, thank you all for your time.
Thank you all.
Thanks, everyone.